Hi everyone, welcome to my presentation on the equity of out-of-pocket costs for MBS and PBS. My name is Hsei and I am from the National Centre for Epidemiology and Population Health at the Australian National University. I would first like to acknowledge and thank all members of the study team, including Rosemary Corder, Nicholas Biddle, Emily Langsa, and Daniel Butler. Generally speaking, there is agreement that to be equitable, costs for healthcare should be according to ability to pay. However, there is no standard or benchmark for what it means for costs to be in accordance with ability to pay. In this study, we choose to measure equity in terms of the degree of progressivity. So if we plot income decile on the x-axis and cost as a proportion of income on the y-axis, progressive payments is when the proportion of cost to income increases as income increases, as can be seen here on the graph to the left. Regressive payments is when the proportion of cost to income decreases as income increases. And proportional financing is when the proportion of cost to income stays the same across all levels of income. Medicare is Australia's universal public health insurance scheme. Medicare includes the MBS, which subsidizes medical services, and the PBS, which subsidizes a range of medicines. Under Medicare, patients often still incur an out-of-pocket cost. This happens when the healthcare provider charges above the Medicare rebate amount. While there are policies in place to contain high out-of-pocket costs, including Medicare safety nets and bulk billing, in this study, we ask, how are Medicare out-of-pocket costs related to ability to pay? Are they proportional, progressive, or regressive? We answered this question by calculating for non-hospital MBS services, PBS medicines, and in total, out-of-pocket costs as a proportion of equivalized household disposable income, which is our measure of ability to pay, and report the mean percentage by income decile. Whether costs are progressive, regressive, or proportional will be seen from how these numbers vary across income decile, as in the graphs in the previous slide. We also report the Kakwani index, which is a summary measure of progressivity. We use data from the Multi-Agency Data Integration Project, MADIP, which linked multiple government administrative datasets via SPINE. The SPINE is created by combining entities from three major national datasets with high population coverage: the Medicare enrollments database, personal income tax data, and social security data. Together, there are over 32 million entities on the SPINE. The SPINE is then used as a basis onto which all other databases are linked. In this study, we use all linkages to the SPINE from the 2011 census, death data, MBS data, and PBS data. The population for our study was defined as all households in the 2011 census where every individual in the household linked to the SPINE. In this manner, we can track every individual's income using their tax and social security data in the 2011-12 financial year, and the out-of-pocket costs from the MBS and PBS data in the next financial year, 2012-13. Now, out-of-pocket costs for every individual were directly available in the MBS and PBS data. However, individual disposable income had to be estimated. We used a hierarchy of information sources, prioritizing the tax data first, then the social security data, and then the census data if income was not available elsewhere. Very briefly, disposable income or post-tax income was defined as taxable income minus tax, where taxable income was directly available from the tax data, but tax itself had to be estimated using ATO taxation rates and criteria as far as was possible. We made an adjustment for seniors over 60, where non-taxable income, for example, superannuation, is thought to be an important source of disposable income. I will leave the rest of the formula here for interested readers to have a closer look. Individual income and cost were then aggregated over the household, such that the household formed the unit of analysis in this study. Not surprisingly, the derivation of income varied across income decile. Richer households are more likely to be in the taxation data. Therefore, as can be seen in this chart here, income for richer households were more likely to be derived from the tax data. The opposite is true for poorer households, where their income is more likely to be derived from the Social Security or census data. In order to address potential biases, we perform sensitivity analysis, where firstly, we only use income derived from the tax data. In other words, we only included tax-paying households. And secondly, we use self-reported census income as the measure of disposable income for the whole population. In this way, in these sensitivity analyses, there is no mixing of data sources when deriving income. This is the result of our equity analysis for Medicare out-of-pocket cost. The blue bars are for MBS cost and the red bars are for PBS cost. MBS out-of-pocket costs were about 1% of disposable income in the poorest decile and 0.6% in the richest decile. Percentage costs were roughly equal across all levels of income in between the poorest and the richest. Therefore, MBS costs were roughly proportional to income. PBS out-of-pocket costs were 1.2% of disposable income in the poorest decile and 0.3% in the richest decile. The percentage cost decreased from the poorest to the richest households, and therefore this shows a regressive pattern. The Kakwani indexes replicate these findings. The graphs here plot cumulative households on the x-axis ranked by income and cumulative income or cost on the y-axis. The diagonal green line here represents perfect equality. For example, if income was distributed perfectly equally, 40% of the poorest households would earn 40% of income. The blue curve here shows the actual distribution of disposable household income in Australia. It can be seen here that around 40% of the poorest households earn around 20% of disposable income. The red curve here shows the distribution of Medicare costs, and we are interested in where the red curve lies in relation to the blue curve. If it sits inside, costs are regressive, and if it sits outside, costs are progressive. On the left, we can see that the MBS cost curve sits almost on top of the income curve, and therefore MBS out-of-pocket costs are almost proportional. This is also reflected in the Kakwani index, which is very close to 0. On the right, we can see that the PBS cost curve lies very much inside the blue income curve, and therefore PBS costs are regressive. This is also reflected in the negative Kakwani index. So in this study, we present one assessment of the equity of Medicare out-of-pocket payments. We found that in 2012-13, MBS costs were almost proportional and PBS costs were regressive. These results held with sensitivity analysis. Our study also demonstrates the use of the newly linked MADIP data in assessing financing equity. Previously, progressivity assessments like this was not possible, as there was no data that linked individuals' income to their healthcare spending. In future work, we'll perform subgroup analyses to assess progressivity by household characteristics and also by self-reported medical conditions. Thank you for listening, and please contact us if you have any questions or comments.